I'm Gerald Devins. I'm a clinical psychologist and a senior scientist at the Ontario Cancer Institute. I'm professor of psychiatry at the University of Toronto, and for many years I've been affiliated with the supportive care program at Princess Margaret Cancer Centre. Aspects of disease like symptoms, lesions, anatomical changes caused by the disease, disability, pain, and so on, or aspects of the treatment like alleviation of symptoms or side effects or time required to complete the treatment, all influence subjective well-being or quality of life indirectly by affecting illness intrusiveness. To the extent that all these aspects of disease or treatment make it more difficult for a person to keep doing the things that are important and meaningful to him or her in life, then the person will experience distress, their happiness will decrease. One very powerful implication of this idea is that if we want to enhance quality of life, preserve quality of life, prevent people from suffering emotional distress, of course we want to alleviate their symptoms, their pain, make the treatments less invasive, etc., because that will reduce illness intrusiveness. But the target for psychosocial interventions that is most directly likely to produce benefits is illness intrusiveness. So if we help a person to compensate, say for example, there are certain disabilities that are irreversible. There are certain problems that are intrinsic to the disease. We cannot change those things. A person can change the extent to which these things interfere with their life and therefore reduces the amount of illness intrusiveness they experience as a result of the same objective circumstances. So people may, for example, learn to substitute a new activity that's more congruent with the limitations associated with their disease and treatment than their previously enjoyed ones. One of my favorite, somewhat, I guess, trivial examples is if I used to enjoy going bowling with my pals every Wednesday night, but now I'm just exhausted, I'm beat, or I've lost the use of one of my legs or whatever, I can't do that anymore. But I could invite them all over to my house. We can watch bowling on TV and drink some beer, yuck it up, and have a good time. And so in that way, I'm still enjoying my life. I'm still enjoying many of the things about bowling that were so pleasurable and valuable to me, even though I cannot go to the bowling alley and do the bowling anymore. People who have head and neck cancer are the risk of getting the disease is increased by things like alcohol consumption and smoking tobacco and probably smoking other stuff too. And the condition is stigmatized, okay? We tend to blame people for their misfortunes when it is possible that their actions could have resulted in the misfortune that has befallen them. And even though a lot of people get head and neck cancer who are not smokers or are not drinkers, it tends to be a stigmatized condition. And so what was happening was people were distancing themselves from that self-concept as a head and neck cancer patient because it was stigmatized. And we found to the extent that people maintained a higher amount of negative stereotype or a more extremely negative stereotype of the stereotypic head and neck cancer patient, the more likely they were to say, that's not me, that they distanced themselves from that concept, and those are the people who seem to be suffering more. We have assumptions about disease, we have assumptions about how it affects people, about who gets the disease and how they adapt to it, how they manage it. And these are very useful because they kind of guide our actions, and especially when we have many years of experience and a high level of education and we keep up to date with the literature, it really gives us great direction. But it can also cause problems if it sets artificial ceilings on what we can expect of people. People are very strong. The average person who hasn't had, trauma, traumatic abuse by parents before they're 11 years old, or all these risk factors, for mental health problems, the average person is comparatively well balanced. And we can expose them to a lot of stress, a lot of threat, a lot of strain. They will suffer, but they're not going to decompensate. They're not going to break. They will not experience an irreversible psychological breakdown that's impossible to bounce back from. They're very resilient. And so I guess that's a message of the illness intrusiveness idea, is that it's the situation that's making me unhappy. If I can learn how to master the situation or compensate for the limitations that are imposed by the situation, I'm going to bounce back and I'm going to be happy. So we want to facilitate that adaptation. We want to facilitate independence, not in a way that passes the buck. Okay, I'm not saying like you signed this consent form, so now you're on your own. If we do it for you, great, but if we don't do it, you can't come and get us afterwards. But rather just to sort of expect people are capable. They can, carry their own torch forward. They can set their agenda. And so, for example, if we locate the suffering in the situation, let's deal with the situation. Let's help the person learn to deal with the situation, rather than making the assumptions that they are demoralized, that they're helpless, that they can't do it on their own, or that they will never, reach those goals.